I had put some thought into all the different things one could talk about in SCI, and I thought that I would try to tailor this talk around issues that I think pertain to surgeons that treat acute spinal cord injury patients. So I'm not going to talk a lot about clinical trials or stem cell trials or various types of neuroregenerative things, because to some extent that probably doesn't affect a lot of people that see spinal cord injury patients in the trenches. So I'm going to talk about things that are just related to acute SCI, and I think hopefully things that treat patients in emergency rooms will find relevant. So I have 4 questions that I just put together at the beginning, and I thought I would pose these. So some of these are going to be kind of quick snappers. So I'm going to talk a bit about translational research. So translational research refers primarily to the development of novel therapies at the bench and bringing these to bedside. True or false? Okay, and then okay, and then next is spine surgeons who primarily are clinicians and don't have a basic science training really have a minor role in translational research. What is your level of agreement with that statement? So do you strongly agree with that statement? Strongly disagree with that statement? Okay, interesting. All right. Now, this is a case, 72-year-old female. She has a fall. She has a cervical hyperextension injury. She presents with absent function in her hands. She has modest weakness in her legs, minimal neck pain. So she presents with a fairly classic central cord pattern of incomplete quadriplegia. What would you do? You would treat her non-operatively, but plan to operate in 6 to 12 weeks after her cord is cooled down, decompress her within 4 to 7 days, or decompress her within 24 hours. So that represents an MRI of an individual that has had a tight cervical canal with an injury, no spinal instability. Interesting. Okay, so there's no injury there though. No spinal instability there. Okay, all right. And finally, current guidelines for acute spinal cord injury management recommend maintaining the mean arterial pressure at about 85 to 90 milliliters of mercury for 5 to 7 days post-injury with vasopressors if necessary. For the choice of vasopressor, your opinion on that? It doesn't really matter, whatever works is fine to get the mean arterial pressure up to 85 to 90? Or you prefer norepinephrine, you prefer phenylephrine, you prefer dopamine, or you prefer some other choice of vasopressor as the means of getting the mean arterial pressure up? Okay, all right. So within that context, I'm going to talk about what I call translational opportunities in the acute spinal cord injured patient. As somebody who trained as an orthopedic surgeon and then went into science and does both, I think that I view translation to be very much of a two-way road. And I think that the role of clinicians in translational research is often really overlooked, because I think that we as clinicians, we're the ones that see the patients. We're the ones that I think see the most important questions that are important to patients. And it's us as clinicians who can actually drive the translational research agenda. And I think that this is often overlooked because people often think of translational research to be more of like developing cells or drugs and stuff and bringing those into the clinic. And so I'm going to put that within the framework of this individual here that presents with this acute cervical spinal cord injury. And when you think of how we would manage this type of individual when they first arrive, while we often think of bench to bedside translational research, and many people, when you hear talk on translational research, they often think, well, what kind of novel therapy could we enroll this patient into for a clinical trial? But the here and now is how us in the room treat these individuals when they come in. And there are a number of aspects to their care that I think are open themselves up to translational research. So firstly, what do we do? Well, we neurologically assess them to determine the degree of impairment. We perform surgery to decompress their spinal cord. We elevate their mean arterial pressure to augment the spinal cord perfusion. And then, of course, sometimes we do enroll these patients into novel neuroprotection clinical trials. So if we look at this spectrum of basic activities that we apply for individuals with spinal cord injuries, I think there are a lot of translational opportunities here. And taking these opportunities and going back to the bench with what we see at the bedside, I think this is a role in which us as clinicians can play an important role in. So starting with this issue of the neurological assessment and the ability to enroll these patients into clinical trials. For those of you that treat spinal cord injury patients, they're familiar with this clinical assessment. So this is the INSCI or ASIA exam. And this is how we evaluate patients that come into emergency room and when we're trying to determine what the degree of neurological injury they have sustained. Now, the problem with this is that it's actually impossible to perform this exam in a high number of patients, either because they have concomitant injuries, traumatic brain injury, or they're just sedated, or from their pharmacological medications, or they're intoxicated. So we've shown that you can actually not do this exam in a high number of patients. Even if you can do the exam and you can say, well, this is a patient with an ASIA A injury, it's this assignment of the baseline injury severity oftentimes is not very predictive of what their ultimate neurological examination is going to be. And finally, it's hard to document, or it's hard to predict how much motor recovery individuals will get based on this initial examination. And it's for this reason that clinical trials in spinal cord injury are so difficult to do, because you need so many patients in order to have adequate statistical power. One of the major areas where people are trying to objectively quantify spinal cord injury is with the use of MRI. And you see these types of parameters being measured, looking at the presence of hemorrhage, the amount of edema, the amount of cord compression, and whatnot. And Michael Failings did this study a number of years ago on cervical spinal cord injured patients to try to use these MRI characteristics to quantify and predict who is a complete injury, who is not a complete injury. And they pulled out hemorrhage, edema, and swelling as being potential factors on an MRI that might help you and distinguish the severity of injury. Also, the degree of cord compression was also helpful in establishing who are the complete versus the incomplete patients. Now, this is a small, unfortunately, a small slide, but they used all of this in combination with clinical factors to try to predict motor or functional outcome after spinal cord injury. And I'll just point to this, and that really what this shows is that the most predictive is actually the baseline ASIA, and MRI adds a little bit there to this multivariate model. So in fact, you can predict motor recovery using the initial ASIA. Hemorrhage and swelling on an MRI can contribute. But in fact, they actually have fairly small coefficients on the multivariate analysis. And that's an interesting, it's an interesting problem, and it makes us ask, well, why is it so difficult to use these very common MRI features in predicting outcome after spinal cord injury? And it's certainly been our experience, and I think others, that the reality is that the MRI image is in fact a snapshot of a very dynamic event. So if you take this individual and do an MRI of them, that MRI will change over time, and because it's a dynamic injury. So in order to characterize that, one really needs to do serial MRI scans done over a period of time. So we just are wrapping up a pilot study at our institution in which we've done serial MRIs in patients with acute spinal cord injuries, doing 6 MRIs in a period of 3 weeks. And we've tried to characterize what's actually happening in the spinal cord, how much edema there is, how that edema changes, how that hemorrhage changes over time. And in doing these MRIs sort of preoperatively, 48 hours after injury, 4 days after injury, 1 week after injury, 2 weeks after injury, 3 weeks, we can actually plot out the dynamic changes that are actually occurring. And it really kind of highlights the fact that if you're going to use MRI to really predict outcome, you need to standardize the time at which that MRI is done post-injury. So this pattern of this gradually increasing edema and then decreasing edema is most pronounced in the most severely injured patients. The degree of hemorrhage probably is mostly reflective of the initial primary mechanical trauma to the spinal cord, and it does not seem to evolve a lot over time. So by doing this serial MRI study where we sent patients to the MRI unit repeatedly after their spinal cord injury, we can see these changes. The edema seems to peak at around 48 hours post-injury, and that those changes are certainly most severe in the severe SCI patients. Aside from imaging, we have pursued a biological assessment of the spinal cord using biomarkers. And so we've been conducting in Vancouver a clinical trial in which we're putting intrathecal catheters into patients with acute spinal cord injuries and taking cerebrospinal fluid for biochemical analysis. And this is to evaluate proteins that might help us objectively characterize what's happening within the spinal cord. We published on this work a while ago and have expanded the study to a number of centers across Canada and also in the United States. So this is data from our first 50 patients that we've recruited with follow-up at 6 months, both looking at how they converted in terms of their ASIA score and how much motor score recovery they achieved. And what we could see here is that you could use these proteins to actually tell you how severely injured the patients were. So these are 3 inflammatory cytokines and 3 structural proteins. And the red are the patients with ASIA A injuries, the blue are ASIA B, and the gray are ASIA C. And while the bar graphs may not look different, this is actually a log 10 scale. So a difference of 1 point is actually a 10 times difference in concentration. And we find that the interleukin-6, tau, S100 beta, and GFAP levels are significantly different between the ASIA A, B, and C individuals. So you can use these to objectively stratify the degree of injury. We can actually also use them to predict ASIA grade improvement. So can you tell using the proteins whether a patient will convert from an ASIA B to an ASIA C or an ASIA A to an ASIA B? Indeed, if you look at all the proteins across the board, the proteins are higher in those individuals that don't convert as compared to those that do convert. So it does tell us something about trying to say, okay, how can we tell at an early stage which individuals have a chance of actually recovering over time? And where this is particularly relevant is in those with complete injuries. So if we look across the spectrum of these individuals with complete cervical ASIA A injuries, is there something that the biology can tell us that would help us decide, well, this is a person with an ASIA A injury that has a chance of converting over time, and this is somebody that simply has probably too severe of a biological injury that they won't convert. So after 6 months, if we compared the converters, those that did improve versus those that did not improve, the proteins, some of the proteins can actually help us here, and in particular the interleukin-6 and S100 beta. So these proteins, the levels of these proteins in patients that are functionally identical at the early stage, all being ASIA A, can help us predict who are those individuals that are going to convert to ASIA B or C down the road. Finally, in terms of predicting motor score recovery, again, all the proteins were highly correlated with motor recovery. So the higher the proteins, the more the damage, the less the motor recovery occurring over time. And where this is particularly helpful is in doing statistical modeling to try to identify those individuals who don't achieve significant motor recovery over time. Because this is what would really help us in a clinical trial if we could say, okay, here's this subset of patients in this trough here that don't achieve any meaningful recovery over time. If they were given a drug and they did achieve motor recovery, then we could potentially attribute that to the drug and not just the spontaneous natural recovery. So our results to date suggest that the biology can indeed help us predict outcome and help us classify injury severity. And we hope that we can develop this into a tool for early stage clinical trials. This is work that we've expanded to a number of different centers. We're also doing the blood. We take serial blood and CSF samples from these patients. and are in the midst of doing an omics analysis of these samples. So we're really trying to map out all the biological processes that might be occurring in response to acute traumatic spinal cord injury, and we have a great team that's helping us with that in Canada. So that's what I'm going to just say about this issue of assessing the neurology in the acute period, and also how that kind of plays a role in enrolling patients into clinical trials. I want to talk next about surgical decompression. As has been pointed out yesterday, this was an important study was done by Michael Failings and the Spine Trauma Study Group members, in which they revealed that surgery within 24 hours of injury had a statistically significant effect in terms of improving your chances of recovering 2 grades on the ASIA scale or more. One of the interesting questions is, how does this actually apply to the most common cervical spinal cord injury that we see today? And that is the injury that I showed you at the beginning, the central cord pattern of cervical spinal cord injury. So the question that in the context of Staskus now, being out for a few years, is in this individual who has this characteristic fall, hyperextension injury, no spinal instability, tight canal, upper extremity impairment greater than lower extremity impairment, would this patient benefit from a surgical decompression? And if so, when should that decompression actually occur? The field is largely undecided on this issue, and in a survey that was done in 2010, an international survey of over 900 surgeons around the world, if you gave them the scenario of a 47-year-old male with a C6-7 bilateral facet lock injury and incomplete spinal cord injury, so incomplete quadriplegia from this type of injury, there was a high support for doing early surgery. So in fact, there was a strong consensus. So if you have a person with a fracture dislocation, incomplete quadriplegia, you should take that patient to the operating room immediately. On the contrary, the 65-year-old male with a hyperextension injury, central cord injury with no fracture, it was extremely variable. About 40% said within 24 hours, about a third 24 to 72 hours, and almost a third in that 5 days to 6 weeks time frame. So wide variation in surgeon preference for the central cord pattern of injury. So that's interesting. So 96% of people would decompress the first case within 24 hours, whereas only 45 would decompress the central cord patient within 24 hours. Now, why is this? This probably reflects both the perception that the central cord injury has a better prognosis for spontaneous neurological recovery than the patient with an incomplete cervical spinal cord injury. And that I think is where a lot of people say, well, you know, we're just going to wait and see kind of how things go, because a lot of them will do fine. Now, is this really rational? There was a series of studies that were done out of the European EMSCI database that looked at central cord injury patients. And this is the third of the 3 papers that looked at longitudinal recovery of motor function. And they actually looked at it based on whether you were a central cord injury patient with really a big difference between the upper and lower extremity motor scores, a central cord patient with a very modest difference, and those that would be considered to be non-central cord incomplete tetraplegics, like that bilateral facet lock injury. And they looked and saw and plotted what they actually did over time, over 1 year, and they followed what their upper and lower extremity motor scores actually did. And what they found was that whether you were a central cord injury quadriplegic or a regular non-central cord incomplete quadriplegic, your motor recovery was about the same. There wasn't actually a major difference in the motor recovery patterns of these two different types of injury. And in fact, the perception that central cord injury has this much better motor recovery, it's not necessarily borne out in the data when you follow these large patient populations over time. And in fact, they're probably better stratified by whether they're ASIA C or D. So their conclusions is that the general assumption that traumatic central cord injury patients have favorable neurological and functional outcomes compared to other motor incomplete tetraplegics, this is not necessarily true based on their study, and that you can't simply attribute this to the presence or absence of traumatic central cord injury. And so it's interesting because when you bring it back to the initial question, when would you operate, and if so, when? What about the question of doing it within 24 hours, which is what the STASCUS study really looked at? So this was a question that we've recently tackled in the AO Spine Knowledge Forum, and have conducted a guidelines exercise according to the grade recommendations. And the grade process is a little bit different for creating guidelines. It takes both scientific evidence and expert opinion and asks more than just what the strength of the scientific evidence is. It asks, it does ask questions about the strength of the evidence, but it also asks about the balance of undesirable and desirable effects, what the guideline implications would be with respect to resource allocation, whether the guideline would be acceptable to surgeons, whether it would be feasible to actually implement. So it's a little bit more complicated than just, well, this is all just class 3 data or class 4 data. And the conclusion is based on the balance of desirable versus undesirable effects. And then you give a strength of the actual recommendation. So based on this, we conducted a systematic review of the scientific literature, which many people have. And it probably focused around this one paper, and I think maybe somebody yesterday pointed this paper out. This is a paper that was done on some of the STASCUS and spine trauma study group patients, and it was about these patients with central cord injuries without fracture. And what they found in a subset of these individuals, so there's not a lot of individuals, 17 patients undergoing early surgery and about 50 undergoing late surgery, was that at least in this subset of patients, there was actually a statistically significant improvement in motor score with early surgery within 24 hours. And there was a statistically significant improvement in functional independence measures in the early surgery patients. So the recommendation that is going to be eventually published from this guidelines process is that there's a suggestion that early surgery be considered as a treatment option in adult patients with traumatic central cord syndrome, recognizing that the quality of the evidence is low, that the strength of the recommendation is weak. We felt that, in essence, the desirable consequences probably outweighed the undesirable consequences about doing early surgery. And while we did not feel that it was strong enough to really suggest that people do this, we felt that it should be at least offered as a potential option. And I think really what this is a suggestion to think differently about central cord injuries. I think it is if you only look at motor recovery, you have a very different picture about central cord injuries. They don't all do well, which is the common thinking. It is probably safe to operate on these patients early, and that's, I think, one of the messages in STASCUS. And the trajectory of their neurological recovery is really not that different from other incomplete tetraplegics that we do rush to the OR with their C6-7 facet dislocations. So really, and that there is this evidence, albeit weak, to suggest that early surgery may be of benefit. So it's really a suggestion that we should be potentially thinking differently about the central cord injury patients. So one of the questions that arises now about the STASCUS study is, why was the beneficial effect of surgical decompression so modest? Because when you look at this, while there is actually the statistically significant improvement or chances of improvement, the reality is that most patients didn't actually improve. The two largest bars on this graph are actually those that didn't improve at all or those that improved 1 grade. So why is that? Why is it that the surgical decompression actually had, in general, a relatively modest effect? This is a patient that has certainly haunted me for a number of years. This is an individual that was in a motor vehicle accident, suffered this C5-6 fracture dislocation. I didn't actually do her surgery, but she went early to the operating room. She had an anterior procedure, open reduction of her facet dislocation. She was treated in our intensive care unit. And she was a C5 Asia A complete patient. And 5 days post-injury, she lost her biceps function and became basically a C4. And so a stat MRI was conducted, and this is what her MRI looked like. So 5 days post-injury, you can see the edema in her spinal cord now, whereas it extended as low as T2, now it goes past the screen, and whereas it extended up to C2 there is now in her brainstem. And you can see the swelling that has occurred within the cord throughout its entire length, and that the hemorrhage within the cord is actually increased. So here's somebody that's been in our intensive care unit, has had her mean arterial pressure kept up at 85 millimeters of mercury for 5 days. She's lost function, and her cord looks like this. So what is happening there? And as a clinician, you may have seen individuals that look like this. And this is where I think, again, it's us as the clinicians that see these problems. It's us as the clinicians have the opportunity to take these questions back to the lab. And that's the bedside back to bench translational research that I think that we as clinicians can have an important role in. So the questions that I think we're interested in is like, so is there pressure inside that cord despite the fact that it's being decompressed? What's actually happening to the blood flow and oxygenation of the spinal cord in this region, despite the fact that we've been driving the mean arterial pressure up with those vasopressors? And what are the downstream metabolic effects of all of these things that we're doing to the cord, all the vasopressors that we're putting in, the mean arterial pressure that we're increasing? And the guidelines recommend 5 to 7 days of intensive care unit treatment with the mean arterial pressure up. So what's happening over this 7-day period? This is obviously a dynamic period of time. So it's very hard to test that in a human, but it can be evaluated in an animal model. And a number of years ago, we established a pig model of spinal cord injury. And one of the reasons for that is the standard rodent model of a spinal cord injury. If you look at a T10 MRI of a spinal cord of a rat and a human, you can see that there are considerable differences between the two, both in its size and in its anatomy. The pig spinal cord looks like this at T10. So it's not exactly the same, but it's much more similar in terms of its diameter. And it does have the surrounding cerebrospinal fluid that you don't actually see in the rodent spinal cord. And from just a rostrocaudal length, it's much more similar in length to the actual human neuroaxis. So one of the first things we did when we had this model is because the spinal cord's close in caliber to the human spinal cord, we can actually interrogate what's happening inside the spinal cord, aligned with those questions that we asked about the human. So we started a study in which we were doing microdialysis measurements of the spinal cord. So by putting in these fine microdialysis catheters into the spinal cord adjacent to the injury site, injuring the spinal cord, and then following what happens over time. One of the things that I was interested in is the difference between this patient here that has the C4-5 bilateral facet dislocation that reduces, and this patient here with the C5 burst fracture. These are patients that have the identical neurological examination. They're both C5 Asia A completes. But I don't think anybody would think that these are these are the same biological injury. So we were interested in kind of saying, well, like what's happening here and here in these two different injury paradigms, which we could assess in our pigs. And we find that you don't have to have a PhD to see that the blue looks different than the red. That the injury that has the sustained compression has a very different metabolic characterization in the adjacent penumbra than the injury that has just the fracture dislocation. So what about additional measures outside that metabolic response? We've designed this setup in which we can do interparenchymal microdialysis, blood flow, oxygenation, and pressure monitoring inside the spinal cord by mounting it on this little frame. And we can do this within our pigs. This is what it sort of looks like. And because we can put these fine catheters into the spinal cord, we can actually monitor these changes over the course of 7 days. So this is what they look like. They do induce a very small amount of damage in the ventral white matter, but it's actually fairly modest, and the animals tolerate it well. We can carry them out to 7 days in these experiments where the monitoring is hooked up to them, and we can track what's happening. It gives us data that looks a bit like this over the 7 days, both. So this is the blood flow, oxygenation, pressure within the spinal cord, both close to and 2 centimeters away from the injury, and also the lactate pyruvate ratio, glucose, glutamate, and glycerol levels within the spinal cord at these areas. So I'm just going to focus on this. This is the pressure and the lactate pyruvate ratio. So what this shows is that over time, there is an increase in the intraparenchymal pressure within the spinal cord, even after the decompression occurs. So the gray is the period at which the spinal cord remains compressed, and then we do a decompression, so the pressure plummets, and it continues to go up, but it never really comes back down, and it remains about 2 times that of baseline, even at 7 days post-injury. For the lactate pyruvate ratio, which is a reflection of ischemia, we see massive ischemia while the compression is on. That's what the gray is. When you take the compression off the spinal cord, the lactate pyruvate ratio comes down. But then it actually never really goes back to normal, even after 7 days. In fact, it's 500 times normal 7 days post-injury. So what it suggests to us is that even though the way we treat patients is with sort of 5 to 7 days in the ICU, the spinal cord at the end of that 7 days is probably still ischemic. And there is probably a level of ischemia that is extending around the spinal cord injury site. And that's something that we probably currently don't take into account with the current way that we treat these patients. So, and there is also increased pressure within the spinal cord, even though it is being decompressed. Now that's interesting because it has introduced the question of whether or not, in addition to doing the bony decompression, we should actually also be doing a dural decompression and opening the thecal sac. And this is work that was actually initially introduced by a guy named Marios Papadopoulos in London, who's written some beautiful work on spinal cord perfusion pressures and spinal cord pressure that was measured with an intrathecal catheter placed right at the injury site. So we took this question back to the lab, and in our model, because as you may recall in our pig model, we actually do have a CSF space around the spinal cord, so we can actually do a duroplasty. And this is a picture from one of our animals in which we do a 10 centimeter duroplasty over the site of the injury. And this is a bit what it looks like afterwards with the ultrasound. And it's interesting, when we did this and followed the animals for 12 weeks, we did actually see a very modest functional benefit in the animals that were treated with a duroplasty, which is to some extent fascinating for us because we've actually never seen anything really promote significant motor recovery in these animals. The question then, of course, is, well, what's actually happening? Like, what's actually going on inside the spinal cord when you do this? This is a question, again, we're trying to answer with our intraparenchymal monitoring. And we're currently in the midst of doing this study where we're doing the duroplasty and measuring oxygenation, blood flow, pressure, downstream metabolic effects to see if this duroplasty is actually changing those intraparenchymal measures. So the final thing I'm going to talk about is this issue of MAP and the augmentation of perfusion pressure. It seems there is increasing evidence that increasing the mean arterial pressure and maintaining it over a period of time, it has something to do with neurological recovery. So there may in fact be some role for this in terms of promoting neurological recovery. This group in San Francisco showed that the difference between the patients here that did not improve, the patients that did improve 1 grade, and the patients that improved more than 1 grade, was really only a matter of 1 millimeter of mercury. So it's fascinating. So what it shows is that maybe even small changes in the mean arterial pressure might have an effect on motor recovery after spinal cord injury. So one of the things that we found interesting is that, at least in our institution, there didn't seem to be any sort of consensus as to what vasopressor you would actually use in order to achieve this. And when we look at the literature, we see it totally across the board. We see some patients or some centers that use phenyl, we see some that use dopamine, we see some that use norepinephrine, and it's hard to imagine that they all have the same effect given that they're pharmacologically, they have quite different properties. So in our institution, we had this sort of, like, some of the anesthetists like to use phenol, some of them like to use norepinephrine. So we asked this question in our model, because it's hard to kind of run a study in a human population, but you can at least ask the question, do these different vasopressors have different activities to the inside the actual spinal cord? So again, if we go back and take that question back to the bench and ask it in our model, we did this similar study where we injured our animals, we had these intraparenchymal blood flow and pressure probes, and we gave them either phenylephrine or norepinephrine. In the first half of the slide, it shows kind of what happens while the pressure, the compression is still maintained on the spinal cord. And we see that really norepinephrine and phenylephrine have a very modest effect at improving blood flow after the spinal cord injury while the compression is still applied. Then we do the decompression here, and we wait a bit, and then we give the drugs again. And interestingly, we find that the norepinephrine will increase blood flow, and the phenylephrine will actually decrease blood flow. So it's interesting, it's fascinating that they would have such a different effect within the spinal cord. Interestingly, though, neither of them really were able to significantally alter spinal cord blood flow, and none of them really altered the lactate-pyruvate ratio, indicating that despite our best efforts, the cord remains ischemic during this period of time. So at least some of the data that we're generating might actually help us inform how we could potentially manage patients to augment their spinal cord perfusion pressure. So I guess the final message there is that, translational research, I think, has a lot more to do than just taking drugs from bench to bedside. And I think that clinicians like us have an important role in driving the translational research agenda. In Vancouver, we're interested in things like establishing biomarkers for injury severity and understanding these acute pathophysiological processes, and then trying to do what we can to understand how to best optimize hemodynamic management for patients. So that's, I think, one of the big messages, because I know that, not everybody has, time to be doing a lot of research in their busy clinical lives, but I think you should not underestimate the role that you can play as clinicians in driving the research agenda towards things that are truly relevant to patients. I'll just close by acknowledging the people in my lab. So I'm very lucky in my institution. I've got great support, great clinical and surgical partners, and a practice that really helps me to devote time to research. I've got fantastic people in my lab, and we're obviously very grateful to the support of our funding agencies. All right, so maybe could we pose the questions again? So as a wrap-up, the questions were, okay, so translation research refers primarily to the development of therapies at the bench and bringing those to bedside. All right, interesting. And spine surgeons who are primarily clinicians do not have basic science training really have a minor role in translational research. Excellent. Okay, and finally, the individual with this traumatic central cord injury. Treat non-operatively, treat initially non-operatively, plan to operate in 6 to 12 weeks, decompression within a week, decompression within a day. Okay. Interesting. Okay. More conservative. Interesting. Well, it was interesting. I would have thought that.
What would you have expected?
Well, I guess I would have expected that more people would be. So is the blue and the orange mixed? Because the first vote was actually 43% for decompressed within.
Yeah.
Well, that's what but I think that it's mislabeled because 43.8% was actually what the first vote was.
People are more aggressive.
People are more aggressive, yeah. So I think that maybe the colors have been switched throughout, which actually kind of makes sense looking at the data. So interestingly, so people would actually think that so people are a bit more aggressive. And I must admit, in my own practice, like when I started my practice, I don't think I ever did a traumatic central cord injury patient like within 12, 14 hours. And I mean, I can't. I think we routinely would sit and wait and maybe decompress 4 to 6 weeks later. That was routinely our practice. So it is, I think, definitely a new part of my practice to actually take an individual with that injury to the operating room within the first day. And then finally, the choice of vasopressors. All right. Okay. All right. Okay, well, very good. Thank you very much.